Imagine stepping into a scorched garden. Like the ground has literally just been hit by a flamethrower, it's heavily tilled, and just left in total structural chaos.
Right, a complete mess.
Yeah, exactly. And now imagine someone hands you a magnifying glass and tells you that somewhere in that devastation, there is a single microscopic seed of an invasive weed.
Which is an incredibly stressful scenario to be in.
It really is.
Uh,
Because if you miss the weed, it takes over the entire garden again. But, if you panic and dig up the wrong patch of dirt, you ruin the soil permanently. And that is exactly what an oncologist faces when looking into the mouth or examining the mucosal tissues of a patient who has just survived intensive cancer therapy.
yeah, it's a really delicate balance.
It is. So welcome to this deep dive. Whether you are a medical professional prepping for clinic or you're just insanely curious about how the human body heals and, well, sometimes fails to, this is for you.
We have a lot of really fascinating ground to cover today.
We do. We have a massive stack of clinical guidelines here from NICE, BH, H&O, BERSH, the British Gynecological Cancer Society, plus a whole raft of radiologic studies. And our core mission today is to answer one incredibly high-stakes question. How do we distinguish the expected brutal aftermath of cancer treatments from the terrifying red flags of a recurrent, non-healing mucosal lesion that needs urgent surgery?
Because, the stakes in this specific scenario are just astronomical. You are essentially looking at diagnostic muddy waters.
Right.
If you mistake a genuine aggressive cancer recurrence for just, the normal fallout of radiation therapy, you delay life-saving surgery. The tumor just keeps growing.
But on the flip side, you can't just go in blindly either.
Exactly. If you jump the gun and perform the wrong kind of biopsy on fragile, irradiated tissue, you can actually permanently destroy that patient's future treatment options. It's this razor-thin clinical tightrope.
So to really understand what's abnormal here, I feel like we have to establish the baseline first. Like, what does a body look like after it's been through the crucible of modern oncology?
That's the perfect place to start because going through these sources, the fundamental issue is that radiotherapy and chemotherapy are incredibly powerful, but they are entirely indiscriminate.
They just attack everything that divides quickly.
Yeah, they target rapidly dividing cells because that is what cancer is, right? Uncontrolled cell division.
Right.
But the human body is full of healthy cells that also divide rapidly, especially the squamous cells that line your mucosal surfaces. So the inside of the mouth, the throat, the vulva.
So the treatment basically can't tell the difference between a dividing cancer cell and a dividing healthy cell.
Not at all. The treatment is essentially causing targeted DNA damage. When chemo or radiation hits those rapidly turning over mucosal tissues, it causes double-strand breaks in the DNA of the healthy basal cells.
Oh, wow.
And because these cells normally turn over so fast, like every few days, the tissue just cannot replenish itself. So the immediate result is acute mucositis.
Which looks pretty horrific on the surface, I imagine.
It does. Visually, you're going to see severe erythema, which is just intense redness, massive tissue edema, and these really painful raw ulcerations. And the body, it tries to patch this up rapidly.
Which is why you see that fibrinous pseudomembrane stuff, right? I saw that term a lot in the guidelines.
Yes, exactly.
It essentially looks like this white, patchy film over the raw tissue. I was thinking of it like a wet scab made out of immune proteins.
That's a really good way to describe it. It's a temporary scaffolding, basically, of fibrin and immune cells trying to cover up the exposed nerve endings and blood vessels.
Okay, so that's the surface, but it goes deeper than that.
Right. The damage doesn't stop at the surface epithelium. The radiation penetrates deep into the tissue bed, and it actually hits the blood vessels. Specifically, it causes something called progressive endarteritis.
And endarteritis is inflammation of the inner lining of the arteries, right?
Exactly. The endothelial cells, the smooth cells lining those medium and large blood vessels, are just highly sensitive to radiation. So they get inflamed, they swell up, and the vessel walls actually thicken inward.
So the vessels physically narrow, which means you get local clotting, and that just suffocates the tissue of oxygen and nutrients.
Yeah, it creates a permanent state of chronic ischemia. So without proper, robust blood flow, normal capillary regrowth is just completely hindered.
Which explains why the healing process is so messed up.
Right. Over months or even years, the tissue undergoes severe fibrosis. It essentially scars from the inside out. It loses its elasticity, its normal immune defenses, and its ability to repair even minor trauma.
Man, that scorched garden analogy really holds up. Which brings us to the first major tool clinicians use to filter the signal of a cancer recurrence from all this noise, which is time.
Time is critical.
Reading through the NICE guidelines, I was actually pretty struck by how rigid they are about the clock. They state that if a patient has an unexplained ulceration in the oral cavity that lasts for more than 3 weeks, that is a massive red flag for urgent referral. But why exactly 3 weeks?
Well, the 3-week mark is tied directly to the body's immune recovery cycle. Typical chemo-induced mucositis is really closely linked to the patient's absolute neutrophil count, or ANC.
Okay, and neutrophils are like the first responder white blood cells.
Exactly. Chemo drops that count to near zero.
Yeah.
But once the chemo cycles actually end, the bone marrow usually starts pumping out neutrophils again within a couple of weeks.
Ah, I see.
So as the immune system bounces back, standard mucositis should just begin to resolve. If an ulcer is still sitting there aggressively after 3 weeks, the biological environment has likely shifted from, acute treatment toxicity to something malignant.
That makes total sense.
Yeah.
But then the British Gynecological Cancer Society guidelines mentioned a very different kind of timeline for vulval lesions.
Yes, they use a 2-week threshold.
Right, but it's tied to an intervention. Like, a lesion is a red flag if it shows a lack of improvement after 2 weeks of treatment with ultra-high-potency topical steroids.
Yeah, the biological logic changes a bit depending on the anatomical site. So in the vulvar region, severe inflammatory conditions like lichen sclerosus or lichen planus are relatively common.
Oh, and those are autoimmune, right?
Right, they're autoimmune conditions that cause these incredibly painful, non-healing ulcers that can visually mimic cancer perfectly.
Wow, okay.
So the ultra-high potency steroids act by forcefully suppressing that local autoimmune response. If the lesion is just an autoimmune inflammatory process, those steroids will rapidly shut it down, and you'll see the ulcer start to heal within 2 weeks.
But if it's cancer,
Carcinomas do not care about topical steroids at all. The tumor will just continue to grow right through the medication.
okay, wait, I'm stuck on this timeline concept for a second. Let me play devil's advocate here.
Sure, go for it.
We just established a few minutes ago that radiation causes progressive endarteritis and deep tissue breakdown that can last for months or even years.
Right.
So if I'm the clinician looking at a nasty oral ulcer on day 22, my first instinct would be that it's just the radiation necrosis we absolutely knew was going to happen. I mean, is a 3-week clock really enough to justify sounding a massive surgical alarm?
No, and you are hitting on the exact dilemma that keeps oncologists up at night. The clock alone is never enough.
Because it just looks the same.
Precisely, because radiation necrosis perfectly mimics a tumor on the calendar. A 3-week-old ulcer absolutely could just be a stubborn patch of dead, irradiated tissue.
So what else do we look for?
This is why the timeline must be combined with very specific textural and structural red flags on the surface. Clinicians aren't just looking at how long it's been there, they are looking closely at the morphology.
And the guidelines are really specific about what a malignant texture looks like. They use the word fungating.
Yeah, fungating is a huge red flag.
That describes a mass that is growing irregularly, right? Like it's pushing out from the surface almost like a cauliflower rather than just being a flat, hollowed-out crater.
Exactly. And in the mouth, persistent red and white patches, so erythroplakia for the red, and erythroleukoplakia for the mixed red and white, those are massive warning signs.
But wait, didn't we say earlier that a white patch could just be that normal pseudomembrane?
Yes, and that is where a very specific clinical test comes in. You have to figure out if that white patch can be wiped away.
Oh, interesting.
A normal pseudomembrane, that temporary scab we talked about, can usually be gently scraped or wiped off with a gauze pad, revealing the raw, bleeding tissue underneath.
Okay, so it just comes off.
Right. But a malignant or pre-malignant white plaque, like oral leukoplakia, is fundamentally different. It's a structural thickening of the cellular layers. It's a process called hyperkeratosis.
So the tissue has actually mutated.
Exactly. It's mutated and built this tough outer layer of keratin. It's structurally integrated into the mucosa, so it absolutely cannot be wiped away.
Okay, but what if the surface is still ambiguous? Let's say it's an ulcer that's been there for 4 weeks. It's a little irregular, but it's really hard to tell if it's a fungating tumor or just a really nasty patch of radiation necrosis.
That happens all the time.
The sources say at that point, you have to look for systemic structural alarms. Because cancer doesn't usually just sit quietly on the surface forever.
Right. If the local surface isn't giving you the clear answer, you look at where the disease would logically travel next.
Which would be the lymphatic system.
Exactly, the body's drainage network. The most immediate systemic red flag is a new, unexplained, and persistent lump in the neck, or palpable hard lymph nodes in the groin, which is clinical lymphadenopathy.
Because those nodes are essentially the drainage filters for the mucosal tissues, right?
Yes.
So if you have a lesion in the mouth and suddenly the lymph nodes in the neck become enlarged, hard, and fixed in place, it strongly suggests the lesion is actively shedding cancer cells into the lymphatic fluid, and those nodes have just caught them.
Precisely. And beyond the lymphatics, you look for signs of deep tissue invasion. For head and neck cancers, the symptoms can be severe and highly specific.
Like trismus, right?
Yes, pain-related trismus is a major one. Trismus is the medical term for lockjaw.
Okay, so how does a tumor cause lockjaw?
Well, the muscles that control the jaw, the masticator muscles, they sit really close to the oral mucosa. So if a patient suddenly cannot open their mouth past a few millimeters, it often indicates that a recurrent tumor has silently invaded deep into that masticator space, causing those muscles to just spasm and lock.
That is terrifying. But there was another alarming symptom mentioned in the guidelines that honestly sounded even worse. The literal expectoration of bone chips.
Yes.
Like the patient is actually spitting out fragments of their own jawbone. From what I read, this is a condition called osteoradionecrosis, or ORN.
That's correct.
So the radiation damages the blood vessels supplying the mandible. The bone tissue actually dies, becomes exposed through the mucosa, and then just fragments.
Yeah, the mandible is particularly vulnerable because its blood supply largely depends on a single main artery, the inferior alveolar artery.
So if radiation thromboses that one artery, the bone just starves.
Exactly. ORN is a known horrific side effect of radiation. But here is the diagnostic trap. A recurrent tumor can also destroy bone as it grows.
Oh man, so if a patient is spitting out bone chips, how do you actually know if it's just the delayed radiation damage or a new aggressive tumor eating through the mandible? I assume we can't just guess based on symptoms. We have to actually look inside.
We do. This is exactly where the radiologic studies come in. Advanced imaging, specifically CT and MRI, becomes the ultimate tiebreaker between dead bone and a new tumor.
And the imaging guidelines provide some fascinating microscopic distinctions that translate to the macro level. Because deep mucosal ulcers and frank bone destruction are completely expected post-radiation due to ORN, like we said.
Right.
So the radiologists have to look at the behavior of the tissue when intravenous contrast dye is injected.
Yes. On an MRI, an ulcer or a mass that exhibits solid enhancement is just a blaring red flag for recurrent disease.
And the mechanism behind that solid enhancement is neoangiogenesis, right?
Exactly.
A recurrent tumor can't grow without a blood supply, so it actively forces the body to build this new, chaotic network of blood vessels to feed it.
And when the contrast dye hits that dense, tangled network of new vessels, the whole mass just lights up solidly on the MRI screen.
But with radiation necrosis, it's different.
Totally different. Necrosis is dead tissue. It has virtually no blood supply in the center at all.
Right.
So when the contrast dye circulates, it might slightly enhance the inflamed edges of the ulcer, but the center of the necrotic area remains entirely dark on the scan. It is literally a biological void.
Wow. So a tumor acts like a solid light bulb on the scan, while necrosis is just a dark, hollow crater.
That's a great visual.
And in terms of the bone destruction itself, if the imaging reveals just the fragmented, destroyed bone without a significant soft tissue mass surrounding it, it leans heavily toward osteoradionecrosis.
Because the radiation just killed the bone.
Right. But if you see a bulky, enhancing soft tissue mass sitting right next to, or physically invading into that destroyed bone, that is the tumor actively eating the mandible.
Exactly. So once you synthesize all these red flags together, the timeline is up. You have an unwipeable plaque, hard lymph nodes, and an MRI showing solid enhancement and a bulky mass.
Then what?
The clinical pathway dictates a very specific and honestly somewhat counterintuitive golden rule of action.
Right. The golden rule across all these guidelines is urgent referral to a specialist multidisciplinary team, or an MDT. And importantly, referring them without waiting for biopsy results.
Yes, that is crucial.
The local clinician shouldn't delay the referral for 2 weeks just to wait for a pathology report to confirm what the scans already show. But the guidelines are incredibly aggressive about what happens next, or rather, what absolutely should not happen next.
This is maybe the most important takeaway.
The primary warning is, do not perform an excision biopsy without histology.
An excision biopsy means taking a scalpel and cutting the entire lesion out in one go with the intention of just removing the problem entirely.
Which feels like the right thing to do. You see a suspected cancer, you want it out of the patient immediately.
It's a natural instinct. But in the context of a post-radiation recurrence, An excision biopsy without a definitive surgical plan can be catastrophic for the patient's prognosis.
And this connects directly to the sentinel lymph node biopsy, right? The SLNB.
Exactly.
Because from what I read in the sources, the SLNB is a crucial mapping technique. Before definitively removing a primary tumor, surgeons inject a radioactive tracer or a blue dye near the lesion to see exactly which lymph node the fluid drains to first.
Right, and that first node is the sentinel.
And if the sentinel node is clear of cancer, you can spare the patient from having all the lymph nodes in their neck or groin removed.
Exactly, which saves them from a lot of unnecessary trauma.
But if you perform an immediate excision biopsy on the primary ulcer first, you physically sever all those delicate lymphatic vessels. You just destroy the local plumbing.
You burn the map before you even have a chance to read it. Once those lymphatic channels are arbitrarily severed by an excision biopsy, the tracer dye won't flow naturally anymore. You permanently lose the ability to accurately stage the cancer.
Yeah, it's tragic.
And furthermore, blindly excising a lesion without knowing its exact cellular makeup might compromise the surgical margins. If the pathologist later tells you it was a highly aggressive carcinoma, well, now you have to go back in and do a much wider, more destructive surgery anyway.
But now you're operating on freshly traumatized, inflamed tissue.
Exactly.
It is a profound clinical paradox. The situation is a life-threatening emergency. The red flags are waving. But the surgeon has to be incredibly conservative in that exact moment.
You have to hold back.
You cannot just drop a bomb on a whole site. You have to take a calculated, microscopic snapshot at the very edge of the battlefield to map the enemy first.
And the technique for that snapshot is heavily regulated in the guidelines. Clinicians are directed to perform a punch biopsy or a wedge biopsy. And the location of that biopsy is absolutely critical.
It has to be taken from the edge of the lesion. Right.
It must be from the edge.
Because if you take a punch biopsy directly from the center of an ulcerated, fungating mass, you're likely just extracting a core of necrotic debris.
Right, the tumor has outgrown its blood supply in the center, and those cells are just dead.
So the pathologist looks at it under the microscope, sees dead cells, and they can't give you a diagnosis. It could be dead from radiation or dead from the tumor choking itself out.
Exactly. By targeting the edge, the transition zone where the abnormal tissue meets the normal tissue, you capture the active front line. You give the pathologist a clear view of the live abnormal cells actively invading the healthy architecture.
And the guidelines add one more critical requirement for that biopsy, which is depth. The biopsy must be taken with a depth of greater than 1 millimeter.
Yes, and that millimeter is everything, because the entire surgical management plan hinges on the distinction between a superficially invasive cancer and a deeply invasive one.
So a shallow scrape of the surface tells you if it's cancer, but it doesn't tell you how deep the roots actually go.
Exactly. If a cancer is superficially invasive, the MDT might plan a more conservative, tissue-sparing surgery. But if the biopsy proves it's deeply invasive, the surgical plan escalates dramatically.
Like massive resections and bone removal.
Right, and complex reconstructive free flaps taken from other parts of the body. A shallow biopsy deprives the multidisciplinary team of the specific architectural data they need to plan a surgery that will actually save the patient's life without causing unnecessary mutilation. Every single millimeter of tissue matters in a post-radiation field.
So to pull all of this together for you listening, distinguishing the chaotic noise of post-cancer treatments from the deadly signal of a recurrence requires this highly disciplined, multi-layered clinical checklist.
It really does.
First, you watch the clock. 3 weeks for an unexplained oral ulcer to resolve on its own. 2 weeks of unyielding, high-potency steroids failing to heal a vulval lesion. Second, you look at the texture. You look for fungating, cauliflower shapes, and white plaques that stubbornly refuse to be wiped away, indicating actual cellular mutation rather than just an immune scab.
Third, you feel for the systemic structural alarms. So new, hard, fixed lymph nodes in the neck or groin, the sudden onset of pain-related trismus locking the jaw, or the terrifying symptom of expectorating bone chips.
And fourth, you rely on the advanced imaging. You don't just look for bone destruction, you look for the solid enhancement of contrast dye and bulky soft tissue masses that actually prove active chaotic tumor neoangiogenesis is happening, rather than just the hollowed-out damage of radiation necrosis.
And finally, when those red flags are identified, you follow the golden rule of action. You refer urgently to the multidisciplinary team, but you keep your scalpel in check.
Right. You biopsy the edge to see the front line. You go deeper than 1 millimeter to measure the invasion, but you never, ever perform an excision biopsy until the map of the battlefield is completely understood and preserved.
And, looking at where this field is heading, there is a fascinating development on the horizon that builds exactly on this
Oh,
challenge.
really?
Yeah, we talked about how difficult it is for a radiologist's human eye to distinguish the solid enhancement of a new tumor from the scattered inflammation of radiation necrosis on an MRI.
Right, because it's so messy.
Well, right now, researchers are training artificial intelligence and machine learning algorithms on thousands of post-radiation MRI scans. And these AI models are beginning to identify microscopic pixel-level patterns of vascular enhancement.
Like the exact chaotic architecture of neoangiogenesis we talked about.
Exactly, but at a level that is completely invisible to the naked eye. So in the very near future, the ultimate tool for filtering the noise of the cure from the signal of a recurrence might not just be a biopsy scalpel, but actually an algorithm reading the shadows.
That is incredible. It really takes us back to that scorched garden we started with. The medical landscape here is incredibly murky, and the traditional tools don't always give you a clean, binary answer.
No, they don't.
You have to look deeper, wait just the right amount of time, know exactly where to take your snapshot, and perhaps soon rely on new technologies to see the patterns we can't. Thank you for joining us on this deep dive into the complex, high-stakes world of post-treatment oncology. We hope this has equipped you with a sharper lens to view these clinical challenges. Keep questioning the obvious, keep learning the mechanisms behind the symptoms, and always keep looking beneath the surface.